Yes, so I'm Stephen Warren, Direct Commissioning from Croydon CCG.
Thank you. I'm Bettina Swain-Chamber, Director of Adult Social Care and Disability Services, Sweden Council.
Good evening, I'm Margaret Mead. I'm Councillor for Heathfield Ward and I'm Vice Chair of this committee.
And I'm Carol Bonner. I'm a Councillor for Fieldway Ward and I'm Chair of this committee.
I'm Councillor Cathy Bee. I'm a Councillor for South Norwood Ward.
Councillor Andy Stranick from Heathfield Ward.
Darragh Morgan, Analyst at Healthwatch Croydon.
And Andrew Pelling, I'm a councillor in Wadden Ward, and this year appointed by the council to be the mental health champion for the authority.
Apologies for lateness from Sean Fitzsimons, but he's coming from the London Bridge direction, so... well, or not, as the case may be. So I think I can probably do the little announcements as well. So in relation to mobile phones and PDRs, council members, officers and members of the public are asked to leave the meeting should you wish to make or receive a telephone call. Don't know whether it is yet, but webcasting, please note this meeting is being filmed for live and subsequent broadcast via the council's internet site. Generally, the public seating areas are not filmed. However, by entering the meeting room, you are consented to being filmed and to the use of those images and sound recordings being used for the purpose described. I don't think there is anyone in the public gallery. And the webcasting system uses the signal from the microphone system, so members are reminded to please speak directly into the microphones provided to ensure your contribution is recorded, remembering to release the button to turn off the microphone off when you finish speaking. And in relation to the pack of papers, if you can refer to the pack page number rather than the report page number, then everyone hopefully knows what they're looking for. And if the fire alarm sounds, you're asked to leave the meeting by the nearest available exit. Good evening, everyone, to this meeting of the Health and Social Care Scrutiny Subcommittee. I am just going to quickly go round and just quickly ask people to introduce themselves for the benefit of the webcast. So I'm Councillor Carol Bonner and I'm the chair of this committee.
I'm Margaret Mead, a councillor for Heathfield Ward and vice chair of this committee.
I'm Bettina Solenti, Director of Adult Social Care and Disability Services.
Stephen Warren, Director Commissioning from Croydon Clinical Commissioning Group.
Councillor Cathy Bee, councillor for South Norwood and a member of this committee.
Andy Stranack, councillor for Heathfield and a member of the committee.
Darren Morgan, analyst at Healthwatch Croydon.
I'm Andrew Pelling. I'm a councillor in Wadden Ward and the council's recently appointed mental health champion.
Thank you, everyone. So agenda item 1 is apologies for absence. We have apologies for lateness from Councillor Fitzsimons, who hopefully will be with us in about 20 minutes. So agenda item 2 is the subcommittee membership chairing in terms of reference. There's an amendment to make to the printed papers, and that's that Councillor Margaret Mead is the Vice Chair and Councillor Andy Stranack is the other member of this committee. Are the membership in terms of reference agreed? Yep. Thank you. So agenda item 3 is the minutes of the meeting held on the 10th of May. Are those agreed as a true record? There's very few of us who were there. Agreed? Agenda item 4, disclosure of interest. The committee need only disclose any interests that do not appear on their annual register of interest. If required at any point during the meeting, forms can be obtained from Member Services Manager. Andy, did you want to?
So I just declare that I've been a member of the specialist user group for the development of the outcome-based commissioning process and continue to be so at the moment.
Thank you. Agenda item 5, urgent business, there is none. And agenda item 6, exempt items, there are none. So agenda item 7 is the Healthwatch Croydon co-option to this committee. And Darren Morgan has been nominated by Healthwatch Croydon. So can I ask the committee to just agree that?
Agreed.
Agreed. Thank you.
Agreed.
Welcome back, Darren. So agenda item 8 is the CCG summary of priorities. So as already introduced, we have Stephen Warren, who's the Director of Commissioning at the CCG. So I think are you going to talk us through the presentation?
Yes, yes, I'm happy to do that, Chair. So what we've provided in the presentation is, first of all, an update on the 15-16 priorities and plans and updates on some of the discussions that we've had previously. And then we'll go on to talk about the priorities for 16-17 and the areas that we're taking forward in this year. Just before we go into the presentation, it's just worth highlighting in terms of some of the key challenges for the CCG over the next year in terms of our deficit position. So we planned this year for a 9.9 million deficit for 16-17. That is in addition to our QUIP programme of 12.8 million. But we have been instructed by NHS England that we need to reduce that deficit further, so the 9.9 million down to 4.2 million deficit in this year. And then with a view to moving to a break-even position for next year. So that does present us with quite significant challenge because we've already developed over the years quite challenging QUIP programmes, and we had planned for, as I was saying, for 9.9 million deficit plan this year, but we are therefore having to identify additional schemes to get us back down to the 4.2 million deficit target that's been set by NHS England. So lot of activity going on in the CC at the moment, trying to look at how we can get down to the 4.2. So it's just worth setting that in terms of some of the context for the presentation. So if we begin then with looking at an update on the 15-16 priorities in terms of the areas that we were working on, and we're going to cover the urgent care reprocurement, progress on outcomes-based commissioning, mental health transformation, reducing variation in primary care, GP practices, and our Together for Health programme. So if we move on to the next slide. So in terms of the reprocurement of urgent care services, so we've had a number of discussions with EOS before about the model that we developed through engagement and then that we then took forward through procurement. So following the engagement process and the modelling work that we did and the procurement, we've now reached the end of that procurement process, and we're at the stage now where we have a preferred bidder, and we're proceeding now through contract negotiations with that preferred bidder to get to a signed contract. So the preferred bidder is called the Croydon Urgent Care Alliance, and it's an alliance of Croydon Health Services, the GP Federation, and another GP organisation called AT Medics. Now, AT Medics currently run the 2 minor injury units at Purley and New Addington. The arrangement is constructed so there has to be a lead in that alliance to make sure that we have an integrated service. So Croydon Health Services will be the lead provider. They'll have the head contract, and then there'll be subcontracts for the 3 GP hubs and for the out-of-hours service as well. And they would also provide the urgent care centre facility, but with the GP Federation supporting GPs to work within that service. So I think we're very pleased with the outcome in terms of we think this gives us a real opportunity in Croydon to develop a really integrated service. And I think there probably are advantages as well in terms of Croydon Health Services providing the urgent care centre as well as the ED department, because it just makes it a lot easier in terms of the integration between those 2 departments going forward. So I think that is an advantage. So we did have quite a good set of bids actually. So there was a good degree of competition in terms of the process. So that was quite pleasing, and it was also really helpful having we had patient reps on our panel. And we had a Health Watch representative as well, and that was really helpful in terms of the process. And actually it's the first time we've had that extent of public Health Watch involvement in the actual procurement process, and it was actually very beneficial. So I think that was something that we'd want to take forward going forward. So that's where we are with the urgent care procurement. One of the issues that we do still need to nail down is the location of the central Croydon hub. So the 2 existing sites at Purley and New Addington will stay as those sites, but clearly with the extended hours and the extended offer as set out in our original offer, the option that the Alliance has come up with around central Croydon, they have presented us with another location, but there is a bit of concern that it might be too near to East Croydon Station, and what we don't want to do is just create demand for people that are just passing through Croydon. So we will be working with them to look at other alternatives, and they have been considering a number of other alternatives as well. But one option would be, for example, to stay at Edridge Road. So we are working through that option. And I think once we have a bit more detail, we can come back and update on that. So that's the urgent care reprocurement. So I think that's certainly heading in a positive direction in terms of contract commencing 1st of April 2017. Then in terms of the outcomes-based commissioning, so quite a considerable amount of work has been taken forward this year. We are still on course for the aim of a contract signed by the 1st of October. So that's the timescale that we are working to. We are now, though, proposing some amendments to the proposal in terms of the provider alliance. We are in discussion with the alliance about how we can further support them in terms of commissioning expertise during a transitional phase, because clearly, as part of outcomes-based commissioning, the alliance will be taking on commissioning responsibility for services, and it's important that we make sure they've got the right expertise for a period of time to make sure that this is successful. So we're looking at how that could be taken forward. Mental health transformation is the next slide. We have made quite considerable investment in mental health services over the last 2 to 3 years. We did, though, end up with a situation at the end of 15-16 where we had quite a significant increase in occupied bed days and admissions, and a lot of demand for beds over and above our contracted levels. So, as a result of that, we've had to delay some of our investments to make sure that we can cover the cost of that within the cash envelope. And that's largely been done where existing services had vacancies or where locum staff were being employed against some of the investments. But we've had to suspend some of that investment to meet the additional demand in occupied bed days. When I come to talk about the priorities for 16-17, I'll cover that in a bit more detail in terms of some of the things that we're looking at as part of that issue. In terms of the work around GP, reducing variation in primary care and GP practices. So we have a fully staffed team which was recruited this last year. They've been working through a number of areas with the practices to look at how we can reduce variation. For a few examples given there in terms of work around CPD, which is respiratory related conditions, asthma, diabetes. And it's very much about making sure that all the practices are adopting the best practice in terms of some of the pathways that we've rolled out across the borough. And it's very much about getting all practices up to the same standard as far as we can. And there have also been a number of tools that have been implemented as well to help us to monitor what's happening in a number of areas, including things like immunisations, diabetes, and some other areas as well. So we've got better information on performance as well. Our Together for Health programme is the next slide. I think we've lost the presentation, but never mind, I'll carry on because it's in the pack. So quite a bit of progress has been made in terms of rolling out the programme. So we've actually been linking a lot of it as well with the outcomes-based commissioning work as well to make sure that what the CCG has been doing is aligned with the new model of care that's being presented by the Provider Alliance as part of outcomes-based commissioning. We also continue to raise the profile of this work with the community and voluntary sector. So the work we've been doing around asset-based community development, that has been continuing in terms of increasing awareness of some of the key messages that we want to get across and using the capacity that we've got in the community and voluntary sector as well. We've also been taking forward a number of pilot projects which include delivery of group consultations, which started in June. We're currently evaluating that. Brief interventions co-production event for professionals and patients taking place at Croydon Health Services. And that is very much about making sure that professionals are equipped to have discussions with patients about shared decision making, and making sure that patients are given ample opportunity to express their views in terms of how they would want their care to be delivered. So rather than, we can't just tackle that at the patient level, we need to make sure that professionals are on board, aligned with that as well. And then the primary care aspect of that is the work we've done with GP practices around shared decision making, which we're doing in partnership with the CVA. And then there's some more detail there in terms of other aspects of the Together for Health programme, which is actually quite an extensive programme of work. We are also now looking at how this can be better aligned with the Live Well initiative that the Council is taking forward through Public Health, to make sure that the Together for Health programme aligns with that as well. So we're starting to look at how that can be better linked together as well, and look at opportunities for collaboration as part of that. So that's a quick recap of 15-16. Shall I go on to the 16-17 and then we can go into questions after that? Would that make sense? Or, yeah. In terms of the flow, yeah. Yes, indeed. So, so in terms of 16-17, so the what I'll talk about is the national and local priorities and then our plans for delivering these priorities. So in terms of the national priorities that were set out in the forward view and NHS planning guidance, there's an expectation around improved performance in a number of areas, so referral to treatment, cancer, A&E, access to psychosis services, IAPT, dementia, cancer, obesity, mental health, learning disabilities, and new models of care around integration. So quite a big agenda really in terms of areas that we need to be focused on. And we also work in a number of these areas with the South West London Collaborative in terms of the STP submission and the STP plan that we've been working on jointly with our South West London colleagues as well. And that covers a number of those areas, as well as looking at future issues around acute services, planned and urgent care. Then in terms of our local priorities, a number of areas in addition really, but they also link to the national priorities. So the outcomes-based commissioning work, which is very much around achieving better integration of health and social care and other services. The urgent care strategy that we've been taking forward through our re-procurement programme. The prevention, self-management, Together for Health programmes, that continues to be taken forward this year. We have further work to do around mental health transformation. We've had a significant agenda around learning disabilities and our transformation plans. A key focus of that is around making sure that we have fewer clients in inpatient beds, in placements across the country, and instead that we have suitable community packages in place for those clients. And we have actually moved from, we had several clients in inpatient provision in what's termed the Winterbourne cohort of patients who had been in inpatient provision for quite a number of years, and we've now got that down to 3 clients, and the aim is by the end of this year to be down to hopefully 1 or 2 clients. And then the focus will then move to how do we prevent admission going forward, so that people don't actually need to go into these placements, or at least, very seldom would they need to go into these sorts of placements. And I can talk a bit more about that programme as well. So in terms of a bit more detail on some of the plans, so we've already talked about the Together for Health, which is our prevention, self-care, self-management, shared decision-making strategy. And some of the... so what this bit of the presentation does, it just gives the foundations that we laid in 15-16 on the left-hand column, and then our focus for 16-17. So in terms of the next set of priorities to take that programme forward, it is about implementing a training programme across Croydon practices to support clinician behaviour and delivery of shared decision-making consultations. Making sure as well that those principles are embedded in our acute and community services as well, so that other health professionals also adopt the same principles in terms of their engagement with patients. Another aspect is developing a Tier 3 management service incorporating Together for Health interventions as well. Then if you move on to the next slide, in terms of, first of all, what we achieved in terms of our mental health transformation, and this next slide just sets out what we achieved in 15-16, which really we probably covered in the previous slides actually. But then in terms of our focus for 16-17, the priorities that we're taking forward are developing all-age core 24 psychiatric liaison services and making sure that they're up to standard. Further work around dementia in terms of making sure that the different components of the services work together, so the mental health services, the voluntary sector, primary care, working effectively to deliver good services for people that are diagnosed with dementia. That includes extending post-diagnosis dementia advisors that we piloted in 15-16. As I was mentioning before, we did see at the end of 15-16 a significant increase in occupied bed days, and therefore we've had to agree with SLAM a programme to suspend some of our investments in order to make sure that we could cover that increased activity. In order to do that, we've had to, one of the areas that we have had to refocus as part of that is we're having to stage some of our planned expansion in IAP. So we had planned we had actually more or less at the end of last year achieved our target around access to IAP services, and there were then plans to further extend that, but because of the position on occupied bed days, we've had to suspend that expansion until we've got on top of the occupied bed day situation. The other things that we are involved with is the review of the place of safety arrangements that SLAM are currently consulting on, and one of the other services that we're having to review as part of meeting some of the gap on occupied bed days is the Foxley Lane unit. So the Foxley Lane unit is it's an 8-bedded female-only unit in Croydon, and it's generally it is actually for patients that are informal. It's not for sectioned clients on section. And it tends to be used as, it's partly used as a step-down facility from other SLAM acute beds, but also there is some step-up access as well. So we are currently looking at that service in detail with a view to looking at alternative community models. We anticipate that we would do a detailed consultation on that change because it is a fairly significant service change in terms of the current model. The other thing as well that we're doing around mental health is we've also with SLAM jointly commissioned some additional support to do a detailed diagnostic to really understand what's driving the increase in admissions and occupied bed days. And that will include doing a detailed bed audit to find out some of the, in more granularity, what are some of the reasons for people being admitted, and to look at what are the things that we need to refocus some of our investment around to try and avoid admission going forward, whether that's social support or social issues, or whether it's issues in primary care. And although we have some anecdotal information in terms of what the drivers might be, I don't think we really understand it at a level of granularity that we need to really start to turn that around in terms of reducing the increase in demand for beds. Because of our financial position, it is really important we get on top of the increase in occupied bed days, because it's only then that we can then start to recommence some of the investments that we had set out to do. So that's quite an important piece of work. And we've just commissioned, following a procurement exercise, mental health strategies to do that piece of work on behalf of the CCG and SLAM, so that we get a detailed understanding of some of the drivers behind the change. And some of that as well will involve looking back at the JSNA and some of the needs that were identified in that, to make sure that we've matched our resources to the level of demands that we have. So quite a considerable piece of work to do around mental health in this year. In terms of learning disability, so as I was saying before, so we have, as part of looking at the cohort of patients that are termed the Winterbourne cohort, so clients that were in long stay inpatient beds for a fair period of time, we did an independent review to look at what were some of the barriers to those patients being discharged back to community services. One of the areas arising from that review was the need for us to look at our local services to make sure that they are able to, that they're able to accommodate these people when they're discharged back into community services. And some of that is around accommodation, making sure that there is suitable accommodation, and we work very closely with our social care colleagues looking at that agenda. And in fact, Patina and myself were at a workshop today where we were looking at, in terms of the different community services for LD. So there's the Community Learning Disability Team, which is provided through Croydon Health Services. There's the Social Care Team, which is provided through the council. And then there's a Mental Health LD service, which is provided through the South London and Maudsley. And one of the issues that we picked up from the independent review of LD was that those services weren't working together in a very coordinated way, and there does appear to be quite a bit of fragmentation in terms of how the teams work together to support clients. So the workshop we had this afternoon was looking at how can we get those teams to work together more effectively. What other services do we need to put in place to cope with LD clients in crisis in order to prevent admission in the first place? Because it's all very well focusing on discharging clients back to community services, but our aim is to then prevent people having to be admitted to inpatient beds in the first place. That's our longer term goal. So there's quite a bit of work happening around learning disability to take that forward. In terms of the next slide, so some of the work we are taking forward around diabetes. So there's a stream of work around upskilling the primary care workforce to make sure that practices, GP practices, have got the right skills to be able to effectively manage diabetic patients within the practice. We are also part of the National Diabetes Prevention Programme, which is and we've managed to get some national funding to work with practice around identifying people before they actually become diabetic, but who have all the signs of becoming diabetic if there aren't interventions at an early stage. So we've developed a scheme with practices to support early identification of some of those clients. And then making sure that we've got comprehensive coverage of diabetic services across the patch. So in terms of some of the other things then around obesity that we're taking forward this year, so we are working with the Children and Young People's Partnership to look at the whole adult and child obesity plans collectively, so to look at the whole pathway from childhood all the way through to adulthood to make sure that that's joined up. And we've also been undertaking, we started undertaking a review of our obesity services as well, including looking at what a Tier 3 weight management service might look like and what would be a clear pathway for clients in that service. And that's partly about preventing the need for more intensive intervention later on. So bariatric surgery is in many ways the end point of that pathway for a lot of people. And it's about what can we do to try and prevent that before it gets to that situation. Cancer continues to be a key national priority, and it also continues to be a key local priority for Croydon. So we are working collectively across London, looking at demand and capacity around diagnostic services and how we can improve access to those. And I think we're doing relatively well in Croydon in relation to that. Patient education and support in primary care is also important for patients that present with cancer and that are diagnosed with cancer. And implementing the Pan-London cancer pathways, including access for GPs to direct access to diagnostics as well, which is part of the plan for 16-17. And then the next slide moves on to some of the focus around improving performance in a number of areas. So we continue to work hard with Croydon Health Services around improving A&E waiting times, and particularly performance against the 4-hour standard. So there's a number of areas that we're looking at in terms of the action plan that we've developed with the Systems Resilience Group to look at how we improve performance. Croydon Health Services is not doing too badly compared to other CCGs in London currently, but there is more we need to do to get back up to 95% on a consistent standard. We're currently averaging at about 93.4, I think it is, year to date. So some of the areas that we're focusing on include making sure that discharge arrangements are effective in the hospital, and working with other stakeholders to look at how we improve discharge processes across the pathway. Further work around looking at the staffing profile within the emergency department to make sure that A, has the right skill mix, and B, that the staffing profiles match the demand profiles on a day-to-day basis. And the other area as well is in terms of, I guess, really focusing more on some of the front-end issues as well. So I think traditionally we had a number of issues around because A&E couldn't admit to beds, that was causing problems in terms of meeting the waiting time target. That hasn't been so much of a problem lately, largely due to the Rapid Assessment Medical Unit, which was established last November. So that's meaning that fewer people are having to be admitted to bed. So that has eased some of the pressure in terms of admissions. But the focus, therefore, is now more on some of that ED staffing and the front-end issues that I mentioned, really, to make sure that those processes are right and working at optimum level. So that's one of the key areas of focus currently. We talked about improving access to psychological therapies before, and we made quite significant progress in terms of getting up to the target level for last year, which was the 15% prevalence target. But as I was saying before, we are having to hold some of the investment on out because of the problems we've got on mental health for this year. And then the next slide is around new models of care in terms of health and social care integration. So the foundation in 15-16 was the work the Council and the CCG did around the capability assessment that we did of the Accountable Provider Alliance and all the work that went into selecting the alliance in the first place. So the focus for 16-17 is very much about ensuring alignment with the South West London Sustainability and Transformation Plan, so making sure that the models of care that are being developed align with the models that are being developed across South West London. And in fact, they do align pretty well, actually, which is good. The intended start date for the new contract is still end of September, beginning of October, in effect. So we're still on track for that currently. In terms of some of the other work around the new models of care and the out-of-hospital strategy, so some of the foundations that we laid in 1516, so we expanded the rapid response service, developed a care home management guide, which is all about equipping care homes to be able to manage people more effectively and avoiding admission to hospital wherever possible. Improved use of step-up beds for people that are unwell in terms of intermediate care capacity. We implemented a roving GP service, which is able to further support the rapid response service, further embedded multidisciplinary case management, and, as I mentioned, increased our intermediate care capacity. So during 16-17, our aim was to refresh the out-of-hospital and primary care strategy, and we've just completed that, actually. So that went to our governing body in July, and that brings together all these different plans and shows how it illustrates how they relate to the South West London STP, but also how they relate to the model of care that's being developed by the Approved Provider Alliance, and also what we need to do in primary care in terms of further development to meet some of our strategic objectives as well, and looking at some of the incentives that we can use within primary care to achieve that. Through that strategy and through the work with outcomes-based commissioning, we're looking at how do we make sure that health, social care, mental health services are properly integrated, and how do we maximise the benefits for patients. And also looking at other opportunities in terms of community provision, which would further reduce admissions. So things like provision of intravenous services in the community, rather than patients having to go to hospital for those, and near patient testing, which is another area. So last couple of slides. Our plans for delivering some of the national and local priorities, in some ways in summary form here as well. So in terms of our re-procurement programme for 16-17, so urgent care services, we've completed the re-procurement. We're now moving towards, we'll be moving towards contract signature with the preferred bidder and then into mobilisation. We will also be re-procuring our intermediate dermatology services, ENT, and termination of pregnancy services as well. Most of those due to the fact that their contracts are coming to an end and they need to be re-procured. Also during 16-17, we will be deciding whether we want to look at that other list of services, so diabetes education, IAPS, intermediate care, mental health advocacy services, MSK, and some of our voluntary sector contracts as well. So we're still reviewing those services to decide what's the best option for taking them forward. And then again, some of the other services that we're looking at as well. So some of the GP enhanced services, anti-coag, the language line service. And then the next slide just shows some of our QUIP plans for this year. So I mentioned before the 12 million QUIP plan that we have in 16-17. And these are some of the key schemes that support that in terms of that efficiency redesign programme. So the further work around transforming adult community services, the work around mental health that we're doing, looking at provision of mental health older adult beds, and that's very much about, through the investment we've made in community services, how we reduce the reliance on inpatient beds. Work around learning disabilities, and that's very much around, as we discharge people from inpatient provision to community-based care, not only is that beneficial to patients in terms of their quality of life, but also, you know, it is more efficient as well from a resource point of view as well. So that's quite important, quite an important programme as well. We're doing a lot of work around continuing healthcare, and we have revamped the continuing healthcare team that the CCG manages to make sure that we have enough capacity to keep on top of our 3-month and 12-month review process that we need to undertake. In addition, we are looking at the data system that supports that team to make sure that we... one of the problems we've had is that the data system that is currently used by the team is it's a very clunky system. It's not very good at forecasting financially in terms of or keeping track of reviews always. So we're looking at a completely new information system as well to support the team. There's quite a bit of work around the cardiology pathway, which we continue to take forward. Respiratory, COPD, diabetes, urology, and then the list on the right-hand side in terms of falls, MSK, epilepsy, paediatric asthma, digestive, end-of-life care, high-cost drugs. So there's quite a number of areas. Not a lot. Quite a few of these areas aren't new actually, but and some of them we did start in previous years, but there's still plans for next year because there's further work to do in a number of the areas that cover those different pathways. And then on the last slide, we've suggested areas which where we might want to have further discussion with scrutiny in the year ahead. So in terms of the mental health programme, because of the issue we had in terms of increased admissions and occupied bed days, we are having to make some variations to service provision. So I'm sure there'll be things that we need to talk about further. So one of the areas that I mentioned was the Foxley Lane unit, which we're currently looking at, which we're currently reviewing in terms of looking at alternative options for that. Still very much at the early stages, but we felt it important to share that today. In terms of learning disabilities, so I mentioned that before really in terms of some of the work that we've done, and what we could bring back and share was the outcome of the independent review that we undertook to look at services and provision of services within the borough, and possibly a further progress report in terms of the work around reducing variation in primary care. So those are just suggestions, might be other areas that the committee would find helpful. So, so that hopefully gives an overview of 15-16 and 16-17. I'm sure there will be questions. Happy to take any questions that you might have on any of those areas.
Sorry, Andrew.
Thank you very much, Chair, and thank you so much for the presentation, which covers so much ground in a very efficient use of time, so thank you very much indeed for that. Chair, I know that in the agenda of the committee going forward over the year that there will be another meeting where there'll be discussion about mental health commissioning, so I wouldn't want to ask too many questions on that, but if I could start by asking questions in that area. Is it... In fact, I think I'll probably just have two questions, if I may, on that. Is it possible to give a feel as to the size of the direction of monies that has had to take place necessarily because of the unexpected occupation of beds, either in terms of the percentage of the proposed increase that was taking place, in terms of additional monies, particularly additional monies that were going to be given to SLAM, or maybe as an amount?
Yes, no, absolutely. So the impact of the increase in 15-16 was an extra 2.8 million on our cash envelope. So quite a significant amount of money. And that's what we've had to look at in terms of how we can fund that in this year from a number of different areas. But as I was saying before, really by looking at the vacancies that we had in services where we had made investments, but not all the investment had been implemented. What we've avoided doing is having to get into any redundancy situations. We've looked at where there were vacancies or where the trusts were employing locum staff to fill some of the vacancies. So that's kind of been the first route. The problem, though, is that only takes us so far. And depending on how activity maps out this year, we may then need to look at other areas. So the Foxley Lane area, for example, that's a current service that we're looking at. So that wasn't a recent investment. That's quite a long-standing service. And we may have to look again at some of the IAT investment that we've made as well. So that's the other thing that we're considering.
One of the slides talked about further investment giving to SLAM, particularly with the laudable aim of trying to get parity of esteem in dealing with mental health issues compared to others. Was that money unaffected then, money that went to SLAM?
So we had made an additional 5.2 million investment in SLAM over the last 2 years. So we felt that was quite a significant move towards parity of esteem. We also made quite a significant investment in CAM services as well. So that was about that was over £1 million. So as part of the measures that we've had to take, we haven't touched the CAM service because we do see that as the key preventative service for the future. So we felt it was important to leave the CAMs intact. And we've tried to look at all those other areas where we think there's less impact. It's fair to say as well that a lot of the proposals to mitigate the 2.8 million, initially they all came from SLAM, so they spoke to the service departments and clinicians about what would have the least impact in terms of looking at potential savings that we could then use to cover the OBD situation. As I was saying before, I think what is really important is that we complete the diagnostic that I spoke about before to make sure that we really understand what the drivers are behind the increase in occupied bed days. And then we think about whether we're targeting resources in the right areas. So I think that's a really key piece of work. And the aim would be to get the report back from that and the bed audit undertaken by the end of August. And SLAM are very much signed up to that, and they were involved in the selection of the support that's going to do that diagnostic. And I think that's really key that we do that, and then that will give us a better understanding of some of the issues, I think.
Chair, I wanted to ask one more question on mental health and then one other question about procurement.
I attended as an observer the JOSC regarding St George's Mental Health Trust, which has recently concluded. But one of the issues that they had was, whereas they were expecting with other measures that they'd put in place a reduction in admissions, actually they saw an increase in admissions. And I know they've done some quite sophisticated modelling on the reasons for that and to try and forward plan, if you like, for what might be in the future. So I'm just really making a suggestion that it might be useful to liaise with them and maybe they might have some insights that might help the SLAM situation.
Yes, and that's a really good point, actually. We are involved in, there's a South West London Mental Health Group, we are involved in that, and we have picked up that they've done some work around that, and I think we'd want to triangulate that with our own diagnostic as well. I think that's a good point, yeah.
Chair, one of the things with trying to cover so much ground so quickly is that some things are passed over very quickly. You know, in terms of the question about re-procuring certain services, and one of those was on advocacy on mental health. What does that mean, deciding whether to re-procure? You know, are there sort of ambitions to put less resources in that area, or you know, what is the background there? And indeed, are there ways of trying to provide for advocacy in a more value-for-money fashion?
I think there are potentially, because we've got, between the CCG and the Council, we've got a number of different providers providing advocacy services. And I think sometimes we might be even duplicating in terms of support that is given to some clients. So it's looking at, you know, do we move to having maybe fewer providers and something that's more streamlined and might also be more cost effective as well. So I think that's what we're scoping out at the moment.
I'm sorry to a sub-question. Is that better for users as well, taking that approach?
I think it would be, because there's so many different providers. I think it's sometimes quite confusing for users in terms of which service they should go for. But I think as long as we get the outcomes right in terms of the service model, I think that should ensure that it is good for service users.
I can augment Steve's answer a little bit. We are looking at the whole area of advocacy and reviewing, because in adult social care we find ourselves in a position of not actually having enough advocacy to meet our statutory duties under the Care Act. So we're looking at that. And then the bit that health commissions is the statutory health, the INHA and the INPA. Well, we commission on behalf of health. So I suppose to look at that in the round and make sure we have more of a robust service in Sweden that's future-proof, but also evaluate the number of providers, you're quite right, who are providing, and look at maybe, you know, where some of them might provide more specialists, have a sort of an approach where the best provider at providing, say, generic advocacy does that, mental health advocacy does that, and then maybe have a framework and we try and build that advocacy, because it's quite, it's not unique to Sweden, but other places, you know, we kind of ran down advocacy services over the years, and now we have to build them up because of the Care Act. So there's a bit of work to be done in the market with the voluntary sector around that.
Thank you very much, Chair, for letting me carry on. My last question. On procurement, and I'm just perhaps in the context of the urgent care provision, are there any conflicts of interest? You know, are there sort of providers, you know, with people who are quite close to the CCG, and if there are any conflicts of interest, you know, how are they managed in terms of you know, providing contract, which actually seems to be quite close to home in terms of what's being looked at?
Sure. So as part of the procurement process, we've been really careful to make sure that we've managed any conflicts really carefully. So no GP, no practicing GP in Croydon that is in any way connected with the GP Federation was on the procurement panel or selection process. We had an independent GP from outside the area on the panel. We also had a retired GP on the panel, but not in any way connected with the GP Federation. So we were just really careful to make sure that we separated out when we came to the selection process. So I think we have managed that quite carefully to make sure that there aren't any conflicts. And clearly, the rest of the panel is formed of commissioners with expertise in particular areas. We had patient representatives on the panel. We had Health Watch on the panel as well, so I think that did make sure that we had, you know, quite a robust process.
Okay, thank you. Who wants to go next? Andy? Or Darren?
In terms of variation in GP practices, in the last year we've acquired 4,000 items of feedback about GPs. In terms of GP access, 20% of complaints actually come from just one ward, and that's South Norwood. We've received comments. I'll give you an example of a couple. Someone said they were number 48 in the phone queue to get their GP appointment. Someone else said they were number 35. One person who really needed an emergency appointment with their GP was actually told on the phone by the receptionist just to go to A&E. And at some GP practices in South Norwood, patients are increasingly being telephone triaged. So you're now much less likely to actually sit and talk to your GP in person. So my question is, are you looking at places like South Norwood?
Yes, a good question. So we do look at access. So we certainly do look at, well, we are looking at access as part of the Verition project, but I haven't seen your particular report. We'd be very interested to see it, actually, because that's the type of intelligence we can feed into the process. I'd say we haven't looked into South Norwood specifically, but we'd be happy to do that as part of the work, definitely. And any feedback from Health Watch would be helpful in terms of that.
So on mental health Foxley Lane, will there be kind of a full-scale engagement with the public on that? I mean, what's the process?
So we envisaged, given the nature of the change, that it will need full consultation. So that's what we're currently looking at. So we're currently just working up the case for change. Because what we do need to be assured of is that if we didn't have that unit, what would be the alternative provision? Again, this was a proposal that came from SLAM in terms of the clinical view, in terms of the long-term effectiveness of the unit, and the suggestion is that by enhancing the community team provision, some of the crisis team provision, we could provide an alternative service that's community-based. So that's what we're looking at. But I suspect we probably will need to do a full consultation on that one, because that is quite a significant service change.
Coming right back to the beginning of the report, where the deficit that you were projecting was 9.9 million, and then NHS England is saying 4.2 million. Have you got first quarter figures yet? Do we know where we are with that deficit after the first quarter?
It's still early days, I think, in many respects. So we've got activity data for the first few months of the year. That is already showing some pressures in terms of outpatient activities. That gives us a cause for concern, and we're looking into that in more detail to understand that. Also, we discovered this last week that there's been an increase in the amount of money that's paid, that we have to pay care homes for funded nursing care. Quite a significant percentage increase nationally, and what that means for Croydon is that gives us an extra 1.6 million cost pressure overnight, which wasn't budgeted for and which we didn't know about until very recently. And this is always the issue, is that there are some unforeseen cost pressures that will crop up. So we are having to look at a number of areas for further quick and further efficiency, and we're currently working those up currently, and clearly we need to come back, I think, when we've done that, in terms of areas that we that would have a significant impact. So that's what we're currently looking at the moment.
But effectively, you've got to find 4 million in savings plus these extra pressures. Do you think that's feasible at all, or are you going to have to come to a compromise with NHS England?
Well, it's I think we are doing everything we possibly can to get to the 4.2 million target. But it does mean that we are having to look at absolutely everything, including reviewing our running costs as well, looking at vacancies that we have in the CCG, looking at a number of further stretch on some of our existing QUIC programmes, So, yeah, so I think we are progressing plans to try and meet some of that gap, but we're not there yet. I think we have a way to go in terms of identifying enough plans to meet that extra stretch and cope with the cost pressures.
And just one more really. I thank you for the information about the year ahead. I think particularly in scrutiny, where we're concerned is where some of these reviews and changes are going to have an impact on frontline services. And I know last year when we were talking to SLAM, they were talking about a safe place for South London. At the moment, we have a safe place in Croydon, and you mentioned it makes, I think, one line in your presentation, which is review SLAM's proposal for section 136, place of safety arrangement. Now, that's the sort of thing that I think scrutiny would really want to drill down on, because that could have an impact on travel. We talked about travel times and all sorts of things. So as we go forward, will you be coming back and reporting back on that?
Yeah. So in actual fact, that proposal has came directly from SLAM. So what they're seeking to do is rationalise the place of safety arrangements on the Maudsley site. I think we've got one bed currently at the Bethlehem. In fact, there was actually a joint OSC to look at that issue. But I think we've got to the end of July to feedback our comments as a CCG. So we're currently reviewing what impact we think that will have. And also talking to our social care colleagues, because clearly it could have an impact in terms of the requirements for the approved social workers to work with some of those clients. So we're looking at that as well.
Right. Okay.
There is a JOSC has been set up for that purpose specifically. They're currently trying to find a date in early September that all the boroughs can manage where SLAM can report back on the engagement exercise that they have now carried out. Darren, did you want to add something to that?
Can I just say there's a place of safety open day at the Maudsley on the 9th of August, where SLAM will be gathering service user feedback. Yep.
Is that their new facility that they've built? Before?
It is at the new facility, and there's been a new recently appointed place of safety manager that didn't exist before. Yeah.
I'm the councillor for South Norwood, so I was very interested in the earlier point. I was going to suggest the same thing, and I have to say that the question that came up was something when I first saw GP variation, it was something that came to my mind. So, yeah, I think we will be having a chat afterwards. Yeah, it'd be really good. In terms of GP variation, I'm new to this, and you may have discussed it before, but I'd like to get a sense of where Croydon sits in terms of comparisons with other areas. Do we have greater variation, average, less? Is it a sort of quite a widespread problem across the country?
Yes, no, I think it is a widespread issue. I think in any borough you'll find variation across a whole range of different issues in primary care. Which is in the main due to the fact that there's a large number of GP practices in any one area. So I don't think we're unusual in terms of it being an issue. I think it's a common issue. Not every CCG has got a variation programme in terms of trying to systematically tackle that variation. It is quite a challenging area because there's so many different variables that you can look at in terms of targeting practices around lots of different indices and performance areas. So we do have to try and prioritise the areas that we look at to try and achieve an impact. So what we're trying to do is identify areas that support some of our redesign work, for example. So say the work we've done around diabetes or COPD, making sure that all the practices are adopting the same guidelines that we've rolled out, looking at things like access, but also where we have a number of indicators that that fall around a smaller number of practices that are sort of adverse. We're doing a more comprehensive review of those practices in terms of their overall development needs. So we've got a bit of a kind of two-pronged approach in terms of looking at practices that across a range of indices don't appear to be doing that well compared to everybody else, but also then working with a wider number of practices around some of these more generic issues where we want to embed good practice.
So do you have any sticks to go with the carrots?
I suppose at the current time, because performance of primary care is still the responsibility of NHS England, so they ultimately have the performance management role. But clearly, if we had significant concerns about practices, we would liaise with NHSE around that, and we have close communication with them. I think some of the other areas where we can influence them is in terms of what we try to do is encourage peer support. If one practice is not doing well in a particular area, we get another practice that is doing better to work with them to try and get them up to a better standard. So it's about trying to, there's a sort of developmental side as well, and supporting practices as far as we can to improve performance. So we do quite a lot of that in the GP networks as well. And we have a scheme called the Primary Care Delivery and Development Scheme, which incentivises practices in the network to work together to look at things like variation, encourage peer review, sort of encouraging that working together to try and improve those practices that aren't doing as well. In terms of the disincentives, I guess if they don't achieve certain outcomes within that programme, then they won't get the funding for it. So I guess it's in some ways it's a stake, but the performance role is ultimately with NHSE. So we have to work quite closely with them if we've got major concerns about a particular practice.
A question about the issues you raised about mental health and the occupancy. What's been the impact on patients? I mean, are people finding, are people being sent elsewhere because there's no beds in Croydon?
So one of the biggest, I guess one of the biggest impacts is, yes, it does increase out-of-area placements, because if all the beds are full at SLAM, then beds have to be found in independent providers. Not necessarily that close to Croydon, although it's not as bad as it was a few years ago. So that's the impact basically. So which is why it's important that we get back within the bed complement that we have.
And will the outcome of the review, the cause of that, will that come here? Will we get to have a...
Yes, so when we've completed the diagnostic, we'll be happy to bring back the results of that, because I think that will be quite informative in terms of identifying, what are some of the underlying issues that we need to tackle. We'll be happy to share that when that's completed. Yeah.
When do you expect that review to be completed?
So the first phase of it, which is the bulk of it, will be the organisation that's supporting us, mental health strategies, are tasked with completing that by the end of August. So we'll have the results after that time. We might then get them to do a bit more work around looking at some of the issues around primary care and mental health as a kind of second phase, but we'll have the bulk of the report back by end of August.
Coming on to diabetes and obesity, I have a minor obsession with activity and sort of the benefits of that. So do you think that there's enough going on in Croydon to help people increase activity levels and recognise the benefits of that?
I suppose our our Together for Health programme supports that in terms of that, the whole prevention agenda, but also public health in the council have a really important role in terms of that as well. So the Live Well strategy that's been developed through Rachel Flowers and within the local authorities, looking at how some of that promotion can be done more systematically across the borough and using the digital platform to support that. And there's a number of services being developed in support of that. So what we're quite keen to do is to make sure that the Together for Health programme fits in with that, and they support each other mutually. So we're looking at how we can do that more systematically across, but also in a way that's evidence-based, because not all programmes are proven to be effective in terms of promoting physical activity. So it's finding out the ones that are evidence-based and really focusing on that. And that's what Rachel has been looking at as part of the Live Well programme. And, we're obviously quite keen to work closely with Council on that initiative.
And just one last question. In terms of the areas where you're aiming to get savings, so what's the area where you're expecting to get, or aiming to get the largest amount of savings, and what do you think are the biggest risks in terms of not delivering the savings?
So do you mean in terms of the additional savings or the existing? Yes. So, okay. So some of the areas that we're looking at. So on the slide pack, towards the end, were the current QUIP schemes, which we're looking at. And they are, just trying to find the slide now. So on page 15. So that was our existing, yes, on 15 of the 16-17 slide pack. So that gave the existing QUIP schemes. Those schemes are all very much around they were all around service redesign and reviewing pathways to make them more efficient. So that's the kind of existing. That was the existing 12 million programme. In terms of the additional areas that we're having to look at, there's a number of areas that we're currently scoping out, so we haven't necessarily concluded that we'll move forward with all of them. That decision will have to be made by the CCG towards the end of August. But just to give you a flavour for some of them, for example, we're looking at our running and staffing costs, so make sure that we use interim staff as an absolute minimum. We're reviewing our service level agreement with our commissioning support unit to look at how we can reduce costs there. So some of it's kind of back office cost reductions. We are also reviewing the primary care development and delivery scheme that I mentioned before as well, to make sure we think that all of it is offering value for money, whether we should be funding all of that or not. So we're looking at that one. We're reviewing our local incentive schemes to practice as well, in terms of whether we think they're all effective. What else are we looking at? We're looking at potentially stopping prescriptions for emollients and food allergies, which people can get from the chemists. We're looking at the investment we make in our referral management service, which costs us over £1 million, to see whether there's other ways that we could support demand management in primary care rather than it going through referral management centre. We're looking at, we've had quite a significant increase in our contract with Moorfields Hospital, which are the services based at Croydon Health Services, but we've seen some quite big increases in some aspects of activity which don't seem to be what we would expect. So we're reviewing that activity in quite a bit of detail. We also may also want to think about IVF funding as well, whether that's something we need to look at. A number of areas really which we're currently scoping to see where we should go with some of those areas. But I think we are now at the stage where we've done as much as we possibly can through service redesign. I think we are now getting into the territory where we might actually have to stop providing some services, because otherwise we'll never get back to break-even position. So we're beginning to get into that territory.
So are these service redesigns that you've done, are they all on track to deliver what you're expecting, or are any of those, you know, still a bit sort of unpredictable about where they might get to?
Yes, the programme, the existing 12 million programme is on track at the moment, but we have we call a quick programme board, and that monitors the projects every week, and we go through projects. If we have any concerns, they are scrutinised and managed quite tightly. So we have delivered that quick programme every year for the past 3 years to plan. So we'll continue to do that for the 12 million. I think our particular challenge is the extra quip that we're having to now find.
Yes, sorry for lateness because of trains and things, but just that last one about potentially looking at cutting certain programmes, and I have to say, just on a personal record, that I think cutting funding in terms of IVF is something that I would find personally very difficult. Having me and my wife hadn't gone through IVF treatments in the past, and get some of it was funded by the NHS. You know, most people in Croydon aren't wealthy enough to fund it privately, and I would be very concerned that if it went back or made it more difficult for ordinary people on ordinary income not to access that service when they need it at the right time. Second, I just want to clarify, you know, alternative medicines, are we funding any of that at the moment? Right, so that's one of the things we haven't funded for a while.
No, we don't fund that at all.
Excellent, okay, good news. The issue of, you mentioned working with public health on some issues like activities and I imagine things like obesity and things, or tackling obesity. But reading through this report, tackling inequalities in health is something that gets flagged up in one area of health. But reading through this, a lot of this is about, you know, we've got this issue and we're going to deal with this, and there's this issue and this is our plan. What I don't get a sense of, and maybe there are other plans out there, is how you are tackling health inequalities and what priorities, because choices are being made all the time of what we fund and what we go. So I'd be very interested, because I'll have some follow-ups to it once I've heard your response, about how does this fit into, in a sense, this sort of health and well-being agenda that we've all signed up to, which is about tackling health inequalities. And we've only had the Prime Minister this last week talking about how, you know, a 12-year lifespan or something, and I think in Croydon that's probably pretty much on the dot. So how does this fit into that whole health equalities?
Okay, so I suppose, I guess one of the, there's probably a number of strands to that. So I think one of the key areas is the work we do with our GP network. So as part of developing our commissioning intentions for each year, we do work with public health to produce public health profiles for each network. So for each GP network, we can identify what are the key issues for that population in terms of inequalities, what are the particular disease problems or issues that they face as communities. And then they then become the priorities for that network. In actual fact, they're all the areas that we've probably talked about in terms of you know, the key health long-term conditions or morbidities that we've talked about, but clearly there are different levels of need in different parts of the borough, and that's the inequalities issue. So the work we do with the networks is that, again, as part of the PDDS scheme, they have to identify the priorities they're going to work on in the network, and then they have to demonstrate that they've made progress in tackling those areas as part of the work they do in year. So, and that the areas that are identified from the public health profiles that they adopt then also feed into our Commission intentions, but at a more granular level for the networks in terms of their particular action plans.
So that sounds, one, interesting, two, good pieces of work, but how do we know if it's successful in identifying the needs of those communities? Just from experience over time, within the say diabetes and stuff has grown, but there's, it manifests it rising in a number of populations, but there are different reasons, and so how do we test that what you guys are trying to do is actually the outcomes that we're most looking for in terms of health inequalities? Because it's not something that we get to see that coming over this or has ever been presented to us. And I just wondered whether down the line it's worth having a look at one or two to see what it actually means. So,
yes, no, we could certainly do that. And just to give you one example, so I think I mentioned in the presentation we received some funding recently as part of the National Diabetic Prevention Programme. And so we've received some money to support practices to identify people before they actually become diabetic. And so as part of that, we're piloting that in 2 networks. They've got the highest prevalence of diabetes. So that's just one example, really. But there are others, and we'd be happy to bring that back in terms of how we translate that inequalities agenda into some of the work we do in the networks. We could certainly do that.
Okay, thank you. So we talked about the health inequalities. How do we understand, again, whether a service that is you're delivering or funding is either facing additional challenges or is underperforming? Is there a way? Is there you're trying to cover a lot on these papers, and so is there? Would you say which of the services? Whereby there are more challenges than others. Not just growth demands from the public. And what potentially are the reasons? Is it, because I'm thinking about having listened to both the social services and the hospitals and the community health trusts and SLAM, a number of them will talk about staffing and the right type of staffing as issues. So I'm trying to get an understanding from your perspective how that sort of feeds in into your decision-making progress and also whether it is really about redesign or is it sometimes about how do we help people get the right staff into positions? Sure.
So it's quite a complex area. But as part of our out-of-hospital primary care strategy, that does include, that for example has a whole section on enablers, and one of them is estates in terms of, state of primary care premises. And then there's another section around workforce because, even just in primary care, there's some quite significant workforce challenges over the next 5 years, given the number of GPs that will be retiring. So that starts to look at what might be some of the alternative models around workforce, how we can use other staff differently, how practices work together as well to provide some services potentially, which is one advantage of having the GP Federation development. It means they could start to look at where they have particular shortages, how they can work together to provide some services, for example. And clearly we have workforce challenges in our providers as well. That's not unique to London, but London has particular problems. So again, we do try to work with our providers to get them to think about the longer term workforce strategy and what they're going to do to try and address some of the problems that they've got in terms of innovative practice, etc. But that is quite a significant challenge for us, I think, in Croydon.
And would you say, in terms of workforce challenges, in a sense, with estates, we mentioned over a number of years you looked at buildings and felt they didn't work, and I've gone along to events with SLAM and the hospital. But workforce challenges is something that I think we've spoken about for a number of years now, and there isn't a magic bullet out there or a magic solution. But do we have, or do you have the internal capacity actually to change that in reality? Is this really a national issue, and it's something that, we need to be talking to in some cases, the medical schools about who they're training and potentially, the final question I was going to add, but I'm going to add it in now, was about Brexit, right? And about the impact on staffing over the years to deliver some of these services. Because it's not just GPs and doctors that or nurses that we're getting from Europe. So I'm just trying to work out how the national fits into the local and whether they together, and also, as I said, these as they would say, an unknown unknown that came along, which was that we're now going to be leaving Europe potentially in the next few years.
So I suppose the main way that we feed into that process is through the Sustainability Transformation Plan, which is the South West London wide plan. So because that is submitted and has to be assured through NHS England, and that starts to address some of the workforce challenges that we've got. So I think that's quite a key vehicle to make sure that we're feeding up issues as well nationally as part of that. I think locally, though, we have to do what we can as well. So just on the primary care side, we are working quite closely with the education providers to think about how we can get more trainees into general practice, for example, and other developmental support schemes which would encourage staff to work in Croydon. The trusts have their own workforce strategies as well, and we scrutinise those plans as well to make sure that they are sufficiently robust. But so I think we have to try and tackle it on a number of different levels. I don't think we know what the impact yet will be of Brexit, but clearly it could have, depending on how policy develops, could have significant impact. So we need to keep an eye on that as well, I think. But I think the STP is the principal vehicle for reporting up nationally in terms of issues that we're identifying at a strategic partnership level.
Some of my questions have been already answered. Stephen, you mentioned, obviously, and we were talking about the mental health review. Did you also include in that review that detailed diagnostic bed analysis? Will that be included as well? Or is the time frame for that because of the work?
No, absolutely. So the diagnostic will look at a number of things. It will do a bed audit as part of the process. So they'll actually go into the wards for a day and look at all the clients in beds on any one day, and look at why they were admitted and what were some of the factors behind that, and what's delaying their discharge potentially. So that's quite a key part of the diagnostic. In addition, they'll look at the demographic data. So they'll go back to the JSNA and look at what's changed since then. They will also, so they'll triangulate a number of different data sources to look at what some of the issues are. And we've got Paul Richards from social care involved in that as well, to make sure we pick up any kind of social care issues as well, and that we join it up as far as possible.
Together for Health, and it talks there about Health Help Now and the self-care app. I'm really keen on making sure that as many apps and digital opportunities are out there, because I think if we're going to encourage our younger people to remember and to be aware of what they should be looking out for on early signs for prevention. So I was wondering, do you know at the moment what the percentage is of our younger people tapping into that sort of methodology rather than making an appointment and go to the GP, which may not happen because they're living with their phones and that's what they have in their hands. So I was keen to, to promote that, and also through our youth organisations, if there's any work, as Croydon has a lot of youth organisations, we could tap into that as well, because the earlier you encourage them to use those, the better.
Yeah, so certainly younger people tend to be more likely to use apps, I think, probably than the older generation. That's certainly something that we're looking at. And I think, again, there's a real opportunity in terms of how we link that with the Live Well initiative, because we don't want to be using different types of apps. We need to make sure that it's all joined up really effectively. So I think there's further opportunity there as well in terms of just lining up our different processes really. So certainly we need to look at what else we can do with young people, and yeah, we can look at those organisations.
Follow up, if I might. I know I focused on the younger people, but as one of the older people who regularly consult the grandchildren on how to do something, and I know Croydon is doing a lot to encourage older people to have the confidence to use what's available. It makes sense that in the future, self-help and at home, and if we're looking at doing more remote diagnostics with GPs as well, I think there's a bit more work that can be done through that. But I certainly wouldn't ask my immediate friend. I'd go to the grandchildren because they're pretty simplistic from me. Could I just take up a point that Sean raised, and that was about knowing what's going on and addressing inequalities. Some years ago we received, I think it came from Public Health, and it was ward profiles, and it was really helpful. So I was wondering, maybe you're not the right person to ask, but I think that would be really helpful to colleagues on the council, because it would enable us to perhaps do some casework and help in trying to identify that. I don't know whether you remember those ward profiles, but they were very useful, and they gave statistics as well. So if they were gathering the statistics and with your input from the GPs as well, we may be able to get an indication of the direction of travel, and if there is something else we can do as well. My final point was going to be, so that we make sure that our youngsters are being trained for the future. There are opportunities to attend the sixth form careers evenings, and I think that's something that a local council could encourage well, and maybe find a colleague to perhaps participate and encourage people, maybe youngsters being put off by something, and they can be reassured to say, well, no, actually, it's a rewarding job and this is what can happen. So just a thought there.
Yes, so certainly that's something we should look at. In terms of the ward profiles, so in terms of the network profiles that we've developed there, I think they're based on the ward profiles actually, but we just try and tune them to the networks. But yeah, so they are produced by Public Health annually. They get refreshed. So I'm sure that will be possible to share those.
Okay. I just thought we're in the early stages of planning it, but in terms of the outcomes-based commissioning for over 65s, in early September, June the 7th, we're going to do some pre-decision scrutiny before the paper goes to Cabinet. That's going to be an afternoon meeting, just because evenings get hard to find. It was suggested to us that would be a good thing to do, just for us to have a final look at it before the Cabinet paper's finalised. So I'm sure you've got an interest in that. So that's a bit of information. In terms of the GP networks, just going back to that, so I made a note. I can't find, but so I think my understanding is that New Addington and Selsdon are part of the same network, and I think when we were talking about or you were talking about the if you like, the distinguishing features of each network for, for comparisons or working together. Obviously, those two areas are very, very different. And I suppose my question is, does the fact that you've got a very deprived area with a much more prosperous area, does that dilute the issues for the more deprived area? Does it make it look like in that GP network there's not such a high prevalence of certain types of either behaviour or health conditions?
No, I don't think it does, because you can they still can break it down within the network. So the priorities of that network would reflect the different needs in the different aspects of the population. When we initially formed the 6 GP networks, we went through quite a long process to corral the GPs to working together in those formations, and some of it was based on just the practicality of the geography in terms of where the practices were based, and some of it was based on we tried to accommodate where we could, where they had good working relationships as well. But I don't think that necessarily disadvantages the more deprived parts of that area, and it would be all reflected in the health profile in any case, because it's broken down by ward as well. So
it's good to have that reassurance. I was, as someone who represents a ward in New Addington, it was just, I was just concerned that might be the case. So when you talked about the plans for delivering national and local priorities, so that's your slide 14, you talked about some of the contracts that are coming to an end. So urgent care, obviously we know about, intermediate dermatology. I suppose what I'm saying is, if there's likely to be any significant service variations as a result of reprocuring those contracts, we would most definitely want them to come to this committee for consideration, because rather than us finding out when residents start contacting us to complain about something that's happening. So if I can just flag those things up. Obviously, there's some which are much... you've got the procurement plans for 2017-18, so those are obviously much further ahead. And I think also if you've got a list of services that you're going to decide during the current year whether you are going to reprocure them. If you decide not to reprocure them, what does that mean?
Well, it all depends really on whether, if they have facility within the contracts to extend them, then we wouldn't necessarily need to reprocure, and some of them do. So the contracts would continue if we don't reprocure them, basically.
Okay, I think I was more concerned that they might just cease. So I just wanted to make that clear. And I think particularly with the QIP plans, you talked about some of the services that you might no longer provide, and I think I would echo what Sean was saying. I mean, he picked on one particular service, but I think if any of those services are likely to be not provided in Croydon in the future, again, that's something that we would want to consider at this committee before any final decision is taken. But I think apart from that, sorry, I've got notes up and down the sides. I think everything else that I would have asked has been covered. So thank you, and sorry you were here on your own, so we're completely put on the spot. And thank you. I mean, I don't know, Pratima, have you got anything that you wanted to add to anything that's been said already?
Well, I just wanted to say, the issue about workforce is terribly important, and it's really great that we've raised it here today. and Steve talked about how we could address that strategically through the SCP South. But actually, there's other ways where we can begin to sort of look at sort of looking at skills across the piece of health and social care. So the outcome-based commissioning, the partners, the APA partners, are developing a model of care. And when you put the voluntary sector staff in, the adult social care, workforce, and health, you begin to then be able to say, but what are the synergies and what can we, do to make the different skills sort of, I use the word synergy, so that we get the best out of, and therefore release some of the more professional staff. Like if social workers can be released by some of the personal independent coordinators that are going to be in the model of care at the front door of the model of care, then actually you get more. You don't then need more social workers, but actually, so you're kind of similarly. If we can use social care, some of our home care and reablement services to go out with the rapid response service and be dedicated to more of the nursing, then we can reduce the demand for nursing. And all these small steps help the bigger picture, I think. So integration is one way of looking, because I don't think there's a panacea. It's a national problem around recruitment in the health and social care sector. The other thing locally is about looking at things like key workers and trying to see if we can do something around the social housing piece. So then we can attract people and retain them, because we're competing also. Even though we've got a South West London plan, we're still competing for staff with those other. So I think it's about us developing, using our regeneration agenda maybe, to think of things like that across health and social care.
Thank you. I hope everyone thinks I think it's been very useful in, setting the scene for at least the next 12 months. And I think, we've had a lot of information tonight which has been extremely useful to us, particularly in helping to plan our work programme, but also being just generally aware of, what might be coming up in the not too distant future. I think certainly in terms of our recommendations, I think the Foxley Lane issue, I think subject to committee's agreement, I think we'd want to add that to our work programme. We can obviously discuss, where it fits in best, and maybe that's in consultation with you with timings. I think that would be a sensible thing to do. I think although we've got if you like, the mental health issues on our agenda much later in the year, but you've got a review which is being completed in August. I think we might want to see if we can accommodate that, earlier than perhaps it's in there at the moment. And these services that might no longer be provided, I think that's something that the committee will definitely want to look at, even on an ad hoc basis. But obviously the more notice we have, the more, the easier it is for us to programme it in.
So that will be completed at the end of August, and then the next OSC will be the one in September. Is it October? Which might be a bit tight, because we'll only have just had the report, but yeah, we could do the kind of headlines from the diagnostic company for that, probably.
So we have got mental health stuff on our work programme, but we might just want to move things around to make it work better with timing, so that it comes to us before a decision has actually been taken on things, so that we've got an opportunity to influence. Does anyone have anything else that they want to perhaps add to recommendations? Andy?
Just reviewing that work you've done on the GP networks profiles, if you could send us some information on that, that would be.
Sean?
One of the issues is any recommendations is, how you fit that into the work programme, which is looking, doing more than 2 items in an evening is, and you've already got some with 3 and 4 items already. And we may need to take a view over the summer whether more resources are needed or somehow. But I wanted to tackle this issue, or I'd like us as a committee to look at health inequalities when working with the public health side. Because I noticed in the report that, in theory, we've got the end report coming in January, that can also float round. And that normally itself is a good piece of work. But I just wonder whether we can make it a bit more, I want to say, practical, whereby we get the report, but also then delve into an area to see how it follows through into practice. That's not something that you can do overnight. So that's in 6 months' time. But it'd be quite good to sort of not just look at the report and themes and actually let's see what it actually means in reality. How does Croydon change its provision of services to meet the needs of local people or local communities or groups of people?
June, had you picked up anything else we ought to be covering here? No. Excellent. Well, thank you very much, both of you. Yes, and particular thanks to Stephen for fielding all the questions on his own. Thank you. Yeah. Okay, so let's just move on to agenda item 9, which is the Health Watch Croydon update. I think we've got a report from you, haven't we? We've got a report from you, Darren?
Yeah, we visited 8 of the borough's 9 anti-coag clinics. We engaged with about 110 people. We found the quality of service to be very good. But not only that, we actually found it to be an improvement on the previous service. Just to give you an example, at Parchmore Medical Centre, people were waiting half an hour. But the new service, some people were actually seen before their appointment time, and nobody was actually seen after their appointment time. So, yeah. I will say that.
Excellent.
But in terms of the complaints about the travel and distance, that sort of thing, services have been reinstated at Selsdon and Old Coulsdon. And I think now that's happened, the service across the borough does actually appear to be very good.
Good, thank you. I mean, it's good to have that feedback, after something's been implemented, particularly when I think we were all lobbied quite hard on the changes, which seem to come from nowhere. So it is, just because I do understand that just because people complain about a change to the service initially, it doesn't mean to say that it doesn't end up being better ultimately. But yeah, that's good to hear. And I think we're very interested in your South Norwood GPs. I don't think it's mine, because mine doesn't tell you what number you are in the queue. No, I'm a South Norwood. Yeah, but no. South Norwood Hill. Yeah.